Well, I'd like to thank Professor Connect for invitation to come back to this very uniquely organized and excellent meeting. It's wonderful to be here. I'd also like to thank Professor Gestetner and Dr. Marcus Hambach for their support and organization of this meeting as well. I have a very general topic and to talk about principles for treatment selection. I'm going to outline some general ideas that hopefully we'll have time to discuss and that will serve as a basis for further discussions throughout the next 13 sessions of the meeting. So I think we have our general guidelines, and the first three are sort of long-standing, and the fourth one, as we just heard about in our last talk, is emerging and going to play more of a role in the future. And I'll speak to that a little bit, but I think the major things we use when we encounter a patient with head and neck cancer at any site is what is the site, what is the subsite involved, the stage of the tumor, whether it's an early or advanced tumor, and some of the histologic variant subtypes, tumor grade, play a role as well. So when we talk about site, clearly the oral tongue and the oropharyngeal or base of tongue are quite different. In this case, both these patients receive surgery, but in general, for oral cavity tumors, we tend to think about surgery first, at least in the United States, and other parts of the world do as well. And for oropharyngeal cancers, we tend to treat these with non-surgical means because of how responsive they are and because of the morbidity of treating those tumors surgically. And within each site, we have multiple subsites, and it would be the same for larynx or hypopharynx or oral cavity. Each has unique anatomic considerations that come into play for thinking about surgery and metastatic disease, the biology of the tumors. Just looking at the oropharynx here, some of the unique considerations when we think of tumors of the tonsil, we know a high percentage of those are infected and have the HPV virus in them, and that speaks some to prognosis, as I'll say more, and I'm sure many others here will say more about during this meeting. And that can affect the treatment selection. We know that tumors of the soft palate tend to be very metastatic to retropharyngeal nodes and have aggressive behavior, and that affects the treatment selection as well. When we talk about histology, there are a number of features which are important, one of them being the differentiation state, so we can have a well-keratinized or a more infiltrative, less well-differentiated tumor. This affects some of how they respond to different treatments, cytotoxic treatments like radiation and chemotherapy. Ploidy is an area that's a little bit controversial, but it's been used in some treatment selection for oral premalignancies or other tumors. And the findings of perineural invasion in squamous cell carcinoma, adenoid cystic carcinoma, desmoplastic melanoma really comes into play with local control, extension to the skull base, and affects our upfront treatment selection. Extracapsular spread, as shown here, plays a real critical role in determining the prognosis of patients and our treatment of our selection of adjuvant therapy. In the example of tongue cancer, we've done some studies to show that patients with no metastasis treated with surgery plus minus radiation therapy have a high 5-year survival rate that's diminished by the finding of positive lymph nodes, and with a further decrement in survival seen if they have extracapsular spread, tumor outside the lymph node capsule. And when we see if we have 2 or more positive nodes that have extracapsular spread, that's a fairly lethal pathologic finding, and these patients need more aggressive adjuvant therapy. So molecular biomarkers are been on the scene for a while, and I don't think in head and neck cancer we're yet at a point where we can prospectively identify these and make treatment decisions, but I think as currently and in the coming years we'll see more clinical trials designed to figure that out. And we'll speak a little bit about human papillomavirus, P16, the EGF receptor, and just in general terms about some of these higher throughput profiling methods. These are some studies that show the EGF receptor and looking at levels of expression. We've already heard in some elegant detail that it's not just the level of expression of the EGF receptor, but mutations and other abnormalities of the receptor can affect response to treatment and patient survival. But Dr. Ang and Luca Milas back in 2002 published this paper in Cancer Research where they took prospectively acquired patient specimens that were taken in the context of large randomized multi-center clinical trials through the radiation therapy oncology group, and they looked at immunohistochemical staining and defined a group as high staining and low staining, and then looked at the impact of high EGF receptor expression on overall survival, disease-free survival, and local regional relapse. And this gave us an indication that EGF receptor overexpression might be used to stratify patients up front in selection of therapy, and trials by Dr. Ang and others are being designed with that in mind. More recently, Stefan Tamam, who's here in the audience, worked with Li Mao to look at amplification of the EGF receptor and how that could predict treatment outcomes for patients with head and neck cancer at different sites treated at multiple institutions. And you can see here that amplification of the EGF receptor, those patients, the gene for the EGF receptor, have a much worse outcome than those who either have gene deletion or normal alleles at the EGF receptor site. Amanda Siri and colleagues published a very interesting paper related to human papillomavirus and their association with oropharyngeal cancers and whether this has prognostic value. So this was based on the supposition that HPV-E7 will increase the expression of P16, which is a cell cycle inhibitor, and that this P16 will lead to cell cycle inhibition and a more favorable prognosis for those patients that have HPV and high levels of P16 expression. For patients that have more tobacco-induced malignancy or other causes that have lower P16, you would expect with or without a human papillomavirus that these patients would not do as well, or that was their hypothesis. And their data bear this out, looking at patients treated for oropharyngeal cancer. Those who have, this is overall disease-free survival, those with HPV-positive tumors that had high P16 levels, those patients fared much better than those who either had lower P16 levels with or without the presence of human papillomavirus. At our center, Dr. Merrill Keys and colleagues ran a study of induction chemotherapy for patients with local regionally advanced squamous cell carcinoma of the upper air digestive tract. These patients received 6 cycles of cetuximab, paclitaxel, and carboplatin prior to definitive therapy, which could either be surgical, radiation alone, or concurrent chemoradiation. And he's followed these patients now for more than 2 years. John Haymack and Lauren Byers took the serum from these patients and did a multiplex assay to look at cytokines and growth factors in the patient's serum. And these are some of the cytokines that they looked at across the top here. And then these are the different patients, and this looks at increased serum level in red and decreased in green. And with using unsupervised hierarchical clustering, we were able to find 2 different clusters. So here you can see people with relatively low VEGF, IL-8, and other angiogenic growth factors and cytokines, and these patients made up cluster 1. And of these 13 patients, none of them had progression events, evidence of local, regional, or distant failure. And for those patients in the second cluster that had higher levels of these factors, that's where the events were found, and there were 6 progression events noted. These are early data and somewhat imperfect, but they show the potential to use serum markers as predictors of treatment outcomes with a particular regimen. So I won't go through this list in exhaustive detail. We're all familiar with staging systems, but there are a lot of, for each tumor site, the T, N, and overall stage are used for treatment selection now for entry into clinical trials like this one published by Dr. Posner and colleagues. This was a study that is a landmark study looking at induction chemotherapy, and whether it includes docetaxel or not, and shows a significant benefit to the addition of docetaxel. But the treatment selection, this was for patients with advanced disease, stage 3 and stage 4, and we'll continue to use this as a type of entry criteria for treatment selection. Now, I'm just going to speak, kind of close, and just say we have a long list. While we have relatively few things we use to stage patients with, we have larger menus now in all areas of treatment: surgery, radiation therapy, and systemic therapy, and now targeted molecular therapy in different ways in which we give them in different settings. Surgery, I think the role of the surgeon is evolving and changing from one of upfront surgery and taking out big tumors to upfront staging surgery, sometimes debulking surgery. We still do some definitive surgery, particularly in the oral cavity. And then now we're getting to an age of having other alternatives for surgery: transoral microsurgery, and now robotic surgery. Then there's planned surgery after surgical therapy, a planned neck dissection, or salvage surgery for those patients that have persistent or recurrent disease. And with radiation therapy, there's a huge menu now with different types of particles, different types of fields and delivery strategies, and different fractionation schemes with and without systemic therapy. And systemic therapy, we have chemoprevention, induction therapy, concomitant, adjuvant, and I guess definitive for recurrent and metastatic disease. So I'll summarize here and turn it over to Dr. Ang and the panel, just to say that site, stage, and histopathology are our main guides for selecting therapy. We need more level 1 evidence to guide the use of biomarkers and selection of different treatment choices. And the menu of treatment options is large, and individualized treatment decisions should be made by experienced multidisciplinary teams that have the opportunity to evaluate the patient up front and make a decision together about what's best for that patient. And as Dr. Singh alluded to, we need to not only keep oncologic endpoints in mind, but quality of life endpoints as well. And our general treatment philosophy is to use the fewest number of modalities that we can to effect a cure. Thank you.